For men with metastatic or locally advanced prostate cancer, the standard treatment has for decades been hormone therapy, with radiotherapy for locally advanced disease. But in recent years, a number of promising new ways to treat prostate cancer have been emerging.
Around 10 years ago, there were new drugs starting to appear in the clinic that looked interesting, and also there was a lot of pharmaceutical interest in developing new drugs for prostate cancer. So we thought it likely there would be new treatments appearing, even if the ones we were looking at the time didn't turn out to be of interest. When we started looking at trial design, we wanted to move away from the standard paradigm, which is to look in relapsed disease and put drugs that look like they're reactive into first-line therapy at the time of diagnosis. So we had 3 different drugs: a bisphosphonate, a chemotherapy drug, and a COX-2 inhibitor, celecoxib. We also decided that it might be interesting to look at some of those in combination. So we ended up with 5 experimental arms.
These new treatment approaches were compared to the current standard of care, which was long-term hormone therapy. Radiotherapy was encouraged for men with locally advanced or localised disease until November 2011, at which point it was made mandatory.
STAMPEDE is now the largest ever randomised controlled trial of treatment for men with prostate cancer. There's more than 7,000 people who've already chosen to join the trial. The men who were eligible to join STAMPEDE were those with high-risk prostate cancer. This covered a fairly broad spectrum of men, but they were united by the fact they were starting long-term hormone therapy for the first time. We included men with metastatic disease. About 6 in every 10 men joining the trial had metastatic disease. The remainder had non-metastatic disease, so that was either disease that had spread to regional lymph nodes or who had other high-risk features. They had to have 2 or 3 out of a high PSA or a high Gleason score or T category 3 or 4 disease. Now, the majority of men had newly diagnosed disease, but a few of them had disease that had been previously treated with local therapy and had now come back in an aggressive fashion. The median age of men joining the trial was 65, and the majority were fit and healthy. The data we're presenting this summer looks at 3 of those original comparisons, which comprise just shy of 3,000 patients.
The first of these comparisons looked at adding docetaxel to the standard of care for men starting long-term hormone therapy for the first time.
So the docetaxel comparison is a group of men that were allocated to the docetaxel group. In our trial, we call them Arm C, and they're contemporaneous patients allocated to the control arm, which we've called Arm A. So that's about 1,800 patients, 1,200 in the control arm, 600 in the docetaxel arm. The hormone therapy was identical in both of those arms, and men who were allocated docetaxel soon after randomization were planned to receive 6 cycles of docetaxel. That was given every 3 weeks at 75 milligrams per metre squared each cycle.
So, does adding docetaxel to standard treatment when men are just starting hormone therapy improve survival?
The data provide compelling evidence that docetaxel, on average, improves survival in this group of men.
What we showed in STAMPEDE was that giving 6 lots of treatment, the same schedule, 3 weeks apart, resulted in a survival gain across the whole trial of around 10 months. And for the men with the worst disease, the disease that had spread at diagnosis, that survival advantage was 16 months.
At this stage, we've got a lot more information about the metastatic subgroup of patients than the non-metastatic subgroup of patients. That's partly because we have more metastatic patients. You'll remember that it's 60% of patients who are metastatic, but also because we have more information, we have more deaths in that group because their prognosis is worse. So we have around 500 deaths in this comparison in the metastatic setting, and only just short of 100 deaths in the non-metastatic setting.
Docetaxel improves overall survival for men with prostate cancer, but it also increases toxicity.
There was an increase in toxicity with chemotherapy, as one would expect. The proportion of patients reporting grade 3 to 5 toxicities rose from about 1/3 in the control arm to about 1/2 in the docetaxel arm.
So docetaxel is chemotherapy, so docetaxel has standard chemotherapy side effects. So the usual things: nausea, vomiting, which are preventable; alopecia, which is not usually that bad; neuropathy, which on 6 cycles wasn't that significant. Neutropenic sepsis is always a concern. Around 12% of patients had neutropenic sepsis, which is a bit higher possibly than in the licensing trials for docetaxel. But it still means that around 90% of men don't get neutropenic sepsis during the treatment. and the usual sort of fatigue type problems. But the majority of men who started the treatment completed it. There's very high completion rates, which does imply that it was reasonably well tolerated. Side effects obviously go up during this treatment period, but post-treatment, if we look at a year, say, the rates of reported side effects are very similar between the docetaxel and the non-docetaxel arms. So there doesn't seem to be a carryover of toxicity, although we haven't analysed the quality of life data yet.
The second comparison looked at whether adding zoledronic acid to the standard of care improved survival compared to the standard of care alone.
The zoledronic acid comparison considered the 600 men who were allocated to Arm B, and they were compared against the same 1,200 men who were allocated to the control arm, Arm A. There we found no improvement in overall survival or in failure-free survival with the addition of 2 years of zoledronic acid. There was no increase in toxicity associated with zoledronic acid, except for an increase in osteonecrosis of the jaw.
In STAMPEDE, osteonecrosis of the jaw was reported in 10 of the men in the zoledronic acid arm, compared to none in the standard of care or docetaxel plus standard of care arms. The third comparison looked at whether a combination of docetaxel and zoledronic acid was beneficial for men with prostate cancer.
The zoledronic acid and docetaxel comparison included about 600 men allocated to Arm E and compared them to the same 1,200 patients allocated to Arm A. So those men on Arm A had docetaxel given in the same way as the docetaxel arm and zoledronic acid given in the same way as on the zoledronic acid arm. We put this combination in because there was some in vitro evidence before the trial that giving those drugs together may have a synergistic response. So we may have expected to see a slightly larger improvement in overall survival.
So looking at zoledronic acid with docetaxel, the results, if anything, look slightly worse than the results from docetaxel on its own. We think probably because of poorer compliance with treatment, not because of a direct inhibitory effect.
There were also 20 reports of osteonecrosis of the jaw among men in the zoledronic acid plus docetaxel arm, compared to none in the docetaxel or standard of care arms. The STAMPEDE trial isn't the only one that shows that men with metastatic prostate cancer benefit from docetaxel.
We looked at the results of the STAMPEDE trial alongside other trials that were similar to STAMPEDE that had looked at the same question, and we pulled those results together in a systematic review and meta-analysis. For those men with metastatic disease, there is a clear benefit of docetaxel. For those men with non-metastatic disease, the results are less clear. There is a suggestion of a benefit for failure-free survival, but there's not enough information on overall survival at this point. Data needs to mature and more trials need to be reported, and then we can look at this question again in the future.
So, what do these results mean for how men with prostate cancer should be treated?
The STAMPEDE Trial Management Group feels that this is practice-changing data, and that docetaxel chemotherapy should now be part of the standard of care for men with metastatic prostate cancer. For men whose disease had not spread elsewhere at that point of starting hormone therapy, we think the chemotherapy could be considered in some cases because of the other advantages that we have observed.
We recommend that it is considered because there was a 40% improvement in time to relapse. So that on its own could be considered a worthwhile benefit, particularly for men who we think are at risk of dying from prostate cancer. So that's men with very high PSAs, no positive disease, things like that. There is further follow-up needed from the various docetaxel trials in the non-metastatic setting, which will inform this further.
With any prostate cancer treatment, there is always a trade-off between the benefits which one hopes to get and the side effects. And there are side effects from almost every treatment and every drug. And in the case of docetaxel, we know the benefit is now clearly demonstrated as a significant increase in survival, life expectancy. The trade-off is having the docetaxel chemotherapy, which can produce, for some men, some adverse effects. So I guess for each man and his doctor, it's got to be a decision. Is the benefit worth the trade-off?
There wasn't any contest as far as I was concerned, because when I heard the results of Professor James's work, I was just so pleased to think that there was somebody could knock this thing, which I didn't want and I wanted really to get rid of, but couldn't, and that I could get extra life out of that. It was a real no-brainer.
Well, in some senses, it's the biggest step forward in systemic therapy since the 1940s. And really, there's been no change to the first-line drug treatment since then. So it's a pretty big advance.
Now that STAMPEDE has shown that docetaxel significantly improves life expectancy, what happens next?
We recognise and appreciate all of the efforts of everybody who's supported the trial so far. That includes the men who've chosen to join the study and all of the centres that have been participating. Particularly in our thoughts at the moment, of course, are the people who've participated in these original comparisons. We don't want to see their participation as done at this stage. We want follow-up to continue. We'd like to come back in 2 or 3 years' time at a point when there's been a meaningful increase in the amount of information available to us so that we can report even more mature data. That will be more mature data overall. There'll be a large increase, no doubt, in the metastatic setting, but there'll be a particularly meaningful increase in the amount of data we have in the non-metastatic setting, which I think will really help us to interpret the chemotherapy data in that subgroup, in that smaller subgroup of men. With the design of STAMPEDE, it's still a very active trial. We have 2 comparisons to which we've already completed recruitment. One was looking at celecoxib, and that stopped early. We've already reported failure-free survival data. But now, because of these analyses, we've hit the trigger point for reporting overall survival data, and we'll be doing that over the next few months, so those data will become available. And the other looked at adding abiraterone, a novel hormone therapy, and we'll be reporting survival data for that comparison in the next 2 or maybe 3 years. Plus, we have 2 comparisons that are open and recruiting at the moment. One looks at adding radiotherapy to the prostate, specifically in the group of men who've got metastatic disease already, and another is looking at adding the combination of both enzalutamide and abiraterone. So those comparisons are both actively recruiting, and the STAMPEDE Trial Management Group has been working hard to make sure that we're able to update the standard of care in light of the new findings from STAMPEDE. We have a new comparison that Cancer Research UK has just agreed to fund, in which we'll be looking at adding metformin to repurpose this very simple oral drug that's commonly used in diabetes. We're also working up a series of other questions that we want to look at, including stratified medicine questions and the potential to look at immunotherapy.
STAMPEDE has recruited a huge number of patients, and that is only because there are a vast number of operating centres, hospitals and clinics around the UK and in Switzerland that have participated in the trial. And without the support of those people in those hospitals and clinics, the numbers in STAMPEDE wouldn't be anything like they are. So again, I think it's a big thank you to all those people for all the additional work that they've taken on